I'm Mark Hennick. This is So-Called Normal. Hey folks, welcome to So-Called Normal. I'm Mark Hennick. Today on the show we have Karim Mamdani. He is the president and CEO of Ontario Shores Centre for Mental Health Sciences, or otherwise known simply as Ontario Shores, a mental health facility in Whitby, Ontario. I'm so grateful that he came on the show. I love having hospital executives in particular on the show because I'm really able to unpack with them what that part of the treatment system is like. And we get deep into it, I think, in our discussion about how hospital and inpatient care interfaces with community care and how it's evolved over the 100 years that Ontario Shores has been around. So I'm grateful to Karim for coming on the show, and I think you'll really enjoy the conversation too. So here's my conversation with Karim Mamdani, the CEO of Ontario Shores. So I want to hear about the stories that you've encountered running a hospital. There are 4 major psychiatric centers in Ontario, are there?
Yeah, that's correct. So there's 4 specialty mental health hospitals in Ontario. Mm-hmm. The Centre for Addiction Mental Health, Ontario Shores, Royal Ottawa in Ottawa, mm-hmm. and then Waypoint in Penetang. So we've got 4 organizations that exclusively serve mental health and addictions clientele from a hospital perspective. Right. So it's it gives us focus.
Yeah.
And it allows us to very much concentrate on that client, which typically most organizations have difficulty managing.
Yeah. Now, what I'm struck by in that list of 4, and I think I've either worked with or at, in some capacity, 3 out of those 4. Actually, no, I went to a fundraiser at the Royal once. But what I'm struck by are the names, of course. The names of all of them sound very warm, when that never used to be the case, right? The Centre for Addiction and Mental Health used to colloquially be referred to as 999, almost as a threat. Ontario Shores, what was the olden days name of that?
Yeah, so it's a really good question. So probably the closest would have been, the Ontario Asylum or Ontario Criminal Asylum or something. Of
often
that nature.
Lunatic Asylum was included.
So there's a
there.
lot of that sort of name and background that comes with that.
So what has led that change? Obviously, a lot changes before you change the name of a hospital. And it's been a while now, of course, that you've been called Ontario Shores. But how does that name, Ontario Shores Centre for Mental Health Sciences, reflect the practice that's happening on your campus now?
So you're quite right. I mean, I think lots change. So interestingly enough, we actually celebrated our 100th anniversary, October 23rd. Wow. So we have been in our community and have been delivering care for 100 years. Mm. And probably what hasn't changed in all of that has been the care and the love and affection, if you will, of our staff or our clients. That hasn't changed. That passion for doing the right thing and looking after our clients has always been there.
And how many staff do you have?
So we're up to around 1,300 staff now. Yeah, so it's
way bigger than I thought it was.
Yeah,
actually.
It's a much larger organization. 350 beds, and we can certainly talk a lot more about that if you wish to explore that. But what has changed, I think, is in 2 big buckets. The first is societally.
Right.
Where we were built initially because Queen Street, Centre for Addiction and Mental Health now, was reaching its capacity in terms of looking after clients. And so there was a movement that we should open up another facility to really deal with the overflow from Queen Street.
And this was 100 years ago.
100 years ago. And so the notion that you simply accepted individuals who were mentally ill, and you basically housed them for the duration of their lives was the prevailing approach at the time. Mm-hmm. And societally, people wanted those institutions to be closed off.
Right. Prisons, essentially.
They wanted them walled up. And if you've been to the Center for Addiction and Mental Health, you'll know that they actually had a wall around.
Yeah. And they've maintained some. Did Ontario Shores have a wall at that time?
No. So at the time, because we were in Whitby, which is sort of our home base, fairly far away from the city, it already felt like you were away, like
Right.
quite far away. And we had a very large plot of land at the time. The government bought a large plot of land, and it included a working farm. It included a number of things. So the notion was that people would go there, they'd live out their lives in a place where they could be safe and society could be safe from them.
Right. So what kinds of people, I mean, when we say society could be safe from them, now we know, of course, that violence and mental illness there's no risk of harm to people, generally speaking. So what kinds of people or what types of struggles were people dealing with who would be sent off to Whitby?
So I would think that you would have the same diagnosis as you might currently have. So people who are suffering from psychosis, from schizophrenia, or individuals who might have very, very acute, sort of obsessive compulsive behaviors. So any of that sort of debilitating extent of illness, you would have somebody come to Ontario Shores, or previously, the asylum. So as society, we had those sorts of issues, and I think what's changed since then has been generally an acceptance.
Sure.
That, 1 in 5, 1 in 4, whatever stats I think that are most comfortable based on the literature that people are comfortable with, are individuals who will suffer from a mental illness at some point in their lives. So this isn't something that you can sort of wall off and put, far away and not worry that it'll sort of disturb the well-being and of society. It is something that society actually has to work with. It is a part of society, and our work should be about treating the illness in a way that allows people to become productive again as members of society.
And that maintains their humanity.
Absolutely. And so if you then think about the second change that's occurred, it's been about care. We no longer think about keeping people for the duration of their lives. We don't think about the fact that once they come to us, that's kind of the end of the road for them, and they don't really have an opportunity to reintegrate into society. In fact, care has changed so dramatically. What we have available to us in terms of tools to assist has changed so dramatically that people are able to leave organizations like ourselves in relatively quick turnaround times, get back out into the community, be a part of returning back to life and wanting to be a part of that life that they had previously.
What does relatively quick mean? I mean, there's always outliers on either side, the 24 hours or the year or more. But what does the general admission length look like?
So again, it depends on diagnosis, but I would say that generally speaking, that you're anywhere between sort of 60 to 100 days. And that's a far cry even from a decade ago. A decade ago, 15 years ago, you might have had people who were, average length of stay would have probably been 6 months to a year.
Wow.
And in probably, like I said, less than 15 years, we've shortened that down to about an average of 100 days.
Now, is that a change in treatment paradigm, or is that a change in funding and requirements to cycle more people through?
No, I really do think it has to do more with the treatment options that are available and some of the supports that are available in the community. So that between those, we have been able to move people in and out of the facilities much quicker.
Right.
And what I mean by treatment is that I think we've become better at understanding what the expectation of individuals coming into treatment might be.
Okay.
So we can map that out much more tightly than we have in the past. So what, again, as you mentioned, there are sort of two ends of that curve that we can control. So people who are extremely resistant and will take a long, long time, and other people who recover very quickly and can move on. But in general, we can map out a pathway that looks at the amount of time that it's going to take for people to work through any given diagnosis with us. And we have clinical pathways and we have clinical standards that we can apply. And so by applying that treatment as early as possible in the person's arrival with us, we can make sure that, in fact, every opportunity is provided for their betterment and then back out into the community.
I'd like to, if you're now, and I should say too that your background isn't as a physician.
No,
you've been working in the hospital leadership space. So I appreciate if I'll try not to ask too many clinically heavy questions, but you do run a major hospital.
No,
right?
absolutely.
So, but in terms of the treatment course or the treatment pathway that patients and clients are facing then versus now. You're staying for 6 months or a year. What does that type of treatment look like then?
So I think in the past, the notion was because people were coming for these very long periods of time, that treatment wasn't necessarily something that you delivered right away and consistently every single day. Much of what was being provided was safety. So
right.
A place where they could live safely, a place where they could receive nutrition and medication safely.
Because the assumption was they're probably not going to get better anyway. Right?
Yes, and or it will take forever.
Right.
So why would we be aggressive in the manner in which we're going to try and treat the illness? Now we're very much looking at every day counts, and so we're going to be aggressive in trying to deliver therapy. We're going to be aggressive in trying to deliver medication, and then to try and get that individual back out into the community as quickly as possible. But that wasn't necessarily the same degree of aggressiveness or same degree of desire previously as well. And quite frankly, the demand has gone up dramatically for the need for service. And I think that is because society has been more willing to talk about seeking help.
Yeah.
And so we have people who are waiting for treatment. And so if we don't become better at being able to deliver care and get people out of hospital, then we're not able to deal with the individuals who desperately need to get into the hospital for treatment. So we're under constant pressure, and it perhaps didn't feel that way in the past.
The more you talk about help and the more you raise awareness, naturally it's a supply and demand economy. The more you're going to increase demand on the services that we have. Now, one of the things that I've often said to people is that, we need a properly tiered or stepped system that not everybody needs intensive inpatient 24/7 care, despite the fact that it might really feel that way when you're in a really bad place. So therefore, how has Ontario Shores broadened out to include more types of care than strictly speaking, doctor comes to your hospital bed?
Yeah. In fact, most of our growth has not taken place in the inpatient side of the house at all. So when we divested from government, so the government ran the facility up until 2006.
Okay.
Since its inception. And then in 2006, we divested from government. That became a separate hospital under the Public Hospitals Act. So if I use that as a bit of a demarcation point to try and compare growth, we were probably at around 23,000 outpatient visits, if you will, in 2006. This past year, we hit 90,000 outpatient. So we've almost quadrupled our volume. And that's where the growth is taking place. Now, many of those clinics that we run are specialty clinics. There's a women's clinic. There's a trauma clinic. There's a clinic for obsessive compulsive disorders. So there's a number of different specialties that we're providing. But each of those, we have 3,000 people on our outpatient waiting list who are on average waiting 100 days. So the demand has been tremendous. And I think that has been part of the need to be able to move much more quickly. On the inpatient side, we are probably running about the same number of beds as we did in 2006, but we have become faster in the turnaround in the inpatient side of the house. And so we've moved from about 100,000 patient days at capacity in 2006, and we're probably closer to about 115 or 116,000 patient days. So that has grown as well because we've been able to reduce length of stay. Now, what that means is that inpatient care is available and is something that we ought to consider for individuals who cannot be managed any other way. And so that's not our first line of treatment, but the final line of treatment when no other option is available for an individual. But we do have, for example, outpatient care, which means you come to the clinic. We have partial hospitalization programs where individuals might come for, a 6-hour period but they don't stay with us. They don't have an overnight stay, but they're literally with us for the day. Often it's used as an opportunity to treat somebody so that they don't get admitted. They've sort of worsened, if you will, in their symptoms, but not bad enough to get admitted. Or they are been just discharged, but they need a bit of a bridge while they're living in the community, and the partial hospitalization program provides that to them. So we have that as something that's available as well. And then we are doing a number of things virtually now. So we have the Ontario Telemedicine Network, which we can use screens, whether it's on your computer, and then our clinician is in-house on their device that can connect. We are using virtual counseling sessions where we're sort of counseling people, but in shorter bursts. And we're having to be quite innovative in those ways because of the demand. So we there's no way that you can see 100,000 visits plus all of the people who are waiting on the list without thinking about ways to support those individuals quicker and quicker and quicker. And so how can we do that? We can do that with face-to-face visits. We can do that with virtual visits. We can do that with shorter counseling sessions that are coached through using an e-therapy type of model. We can do that by using OTN. So there's a whole range of different tools that we have available. And each of those, then once a person starts to get better, we start to look at how we bridge them back to community-based agencies which can either support them, or if they're in a specialty clinic with us, how we might be able to support them over a prolonged period of time before we discharge them.
Now, this is, of course, or maybe it's not, of course, maybe it's not obvious, but to me, an ideal kind of situation or a nice on paper for how the system would work. But I'm struck by how you said inpatient treatment is when there's no other option available. How much of it is of your inpatient treatment are you saying it's because there's no other option accessible, that there might be other options? We know that more than 80% of people who get treatment for depression recover, that most people recover from depression. But most people don't have readily accessible treatments that do work. So they're winding up in hospital. Do you see this happening a lot?
So I would probably break that up into two components. So the first thing is, of course, we want to continue the education of the general population about mental illnesses generally, so that what you do is you learn and observe and assess those early in someone's illness and not wait for that to get so bad that it requires hospitalization. So, of course, we want to do that as early as possible, and then it can probably be started in terms of treatment fairly less aggressively in a doctor's office, in community clinics, etc. But what I would say is that we know that irrespective of how early we get to dealing with an illness, sometimes there are underlying genetic issues that prevent the person from, for example, they're just resistant to the medication. They have much more acute breaks with reality in terms of their psychosis. Their effect forces sort of behaviors that are extremely aggressive and dangerous to themselves or to others. There are no known therapies to deal with those individuals just on a community basis at the moment. That doesn't mean that the future can't allow us to be able to do that. But right now, that's not the case. And so for those individuals then, inpatient hospitalization becomes particularly important. Now, at our hospital, you can't get access to those beds simply by walking in off the street.
Well, and this is partly what I'm wondering, right? If and I think others have raised this as well, is the system being clogged up in some respect by people who don't need that level of service necessarily, but who don't have any other option?
Yeah, so I would say that on the admission side, that wouldn't be Ontario Shores' experience. So because anyone who's being admitted to an inpatient bed at Ontario Shores has to be referred.
Sure. And it takes a bit of just geographically actually getting out to your facility.
Yeah, and
too, right?
you think about whether it's a psychiatrist in the community, whether it's a hospital that has already been treating somebody, they've been working with that person perhaps for a week, for 14 days, can't manage to make that person well. They need access to our specialization and our sort of ability. So anyone coming into our inpatient side of the house, we don't take them in from an emerge. We don't have an emerge. They can't walk in off the street and say that they need service. So our inpatient side of the house is as tight to get into as you can possibly make it.
Right. By design.
By design. Yeah. And so the whole idea is to maintain people as much as possible in the community. When they need access to us, it's because everything else has failed. So they're now getting admitted to our facility. Now, to your comment, I think that once we have gotten them to the point where we feel that they can now leave, we have difficulty discharging them.
Okay.
And I believe that that's because of a couple of issues. One is that resources in the community may still not be capable, even though we feel that they're now ready for discharge. Resources in the community may feel that they're not capable of managing that individual, even then.
Right.
And so we will hold a case conference. We will talk about, here's Karim, here are the sort of diagnosis that he has, here are the care plan that we've put them on. Here's what we will do to support them, even in the community. Can we, in fact, discharge them to you or agency A, agency B, agency C? And oftentimes what we hear is, no, we can't accept that type of patient for any number of reasons. And so they end up staying a little bit longer with us than the patient, or we, the provider would like, because we don't believe that that's healthy for either party. And
then do you tend to see kind of a peaking of the curve if they're in too long? It's counterproductive?
Oh, definitely. Yeah. You never want anyone to be in a hospital in an inpatient setting for longer than they absolutely have to be, because think about it as just, we talk a lot about the boomerang generation and in young people going back home. So the longer a young person stays at home, the more they become comfortable with certain things being done for them.
Sure.
And I don't
certain
think
institutionalization.
That's
basically.
right. And that doesn't become any different for someone who is suffering from an illness and is now at hospital for longer than they need to be, and we don't want that. So what we try and do is aggressively move them. I think the other part that keeps them in is sometimes behaviors are very difficult to manage. And so say we're trying to discharge, not necessarily to a community agency in our local geography, but let's say we're trying to discharge them to a long-term care home or a nursing home and they're elderly. And they've had in the past perhaps a sexual disinhibition, or they've had behavioral outbursts. And, those organizations would worry about the safety of their of their other clients and their staff. And so if they see any of that on, if you will, the record of this individual that we're sharing, and we're saying, okay, here's the discharge plan, and here's how you're going to manage them. If they see that, often there are times they'll say, nope, we don't want them. So we have to work extra hard to try and figure out a plan, a behavioral plan that they could manage. But almost always, as the second that starts to show up in the behavior in the home, they immediately
get scared.
They get scared and they send the individual back. So we have to work these things through, not only in the community, but with these other institutional providers, so that we don't tie up these precious inpatient resources for people who desperately need them, that have to come from other organizations.
Yeah, I've always, this is an area of I think the treatment system that I've always been passionately opinionated about, but interested in as well. I was in and out of inpatient psychiatric care myself 7 times, and it's the old idea that nothing changes if nothing changes. If you're discharged into the exact same situation that put you in there in the first place, without any real follow-up care, without community services who know how to support you, then it's a cycle. And then the danger of that cycle, at least I experienced, and certainly clients that I've worked with too, is that you then become the frequent flyer, right. The person who the more help they need, the less help they get. And I think that plays into that institutionalization. Even if they are in and out a lot, then they get labeled as somebody who's unhelpable. And I don't think that seems to be very productive.
100% agree. What we generally find is readmissions to Ontario Shores are probably lower than where we might see across the system. And I think that's partly because of the way in which, again, admission has to be prioritized for admission at our facility. Mm-hmm. So if you were treated at I'm going to say a general hospital that has an emergency, mm-hmm. and you're discharged from that hospital, and you go back out into the community, if you needed readmission again, or you felt you needed readmission again, you might go back to the emergency of that general hospital, the emergency room of that general hospital, mm-hmm. And hence the cycle would start again. Mm-hmm. Often with us, when we are discharging somebody back out into the community, we will try as much as we can to work with a community-based agency or another institution, mm-hmm. to make sure that the care plan that we have developed for the individual is followed through. If they deteriorate again in the community, the likelihood is they're not being readmitted to us, but probably being readmitted to one of those agencies, right. or hospitals first. Mm-hmm. And then if, again, treatment is needed beyond the capacities of those providers, they'll get readmitted to us. Mm-hmm. So we monitor both our institutional specific readmission rate, if you will, and our readmission rate for our clients, regardless of where they get readmitted. And, that way we try to understand whether or not the supports that we tried to put in place for that individual failed, and how we should be doing something different. What
an interesting way to frame that consideration of the problem. So maybe I'll ask you, if somebody is readmitted a lot, if they're in and out of hospital a lot, is it because of any lack of something they're doing, or is it that the system is failing them?
It's not a satisfying answer, but I'm going to start by saying it depends. Maybe start then first with the individual. There are certain expectations or accountabilities for the individual, mm-hmm. in the management of their own health, and whether that so we may have a plan that we have set out for them that looks at their nutrition, that looks at their exercise requirements, that might look at their medication management, the fact that they have to be on medication. So there are a range of different things that we would say, if you're able to do these things, the likelihood of your successful reintegration into community is much higher. And if, on the other hand, you fail to do some of these things, and the failure is not necessarily because they don't want to do it. They might be because of a reoccurrence of their disease that deludes them into believing that they don't need to follow the protocol that's been established. But if they don't do those things, then the likelihood is they'll be less successful integrated into the community.
Or sometimes the treatment is working and the symptoms subside, so they don't think they need it anymore.
Exactly. So some of that is, if you will, person-centric or client-centric in terms of reasons they may get readmitted. And sometimes it is about the lack of a system. Mm-hmm. And so although we have tried to do a warm handoff to a provider in the community, we may not have done a good enough job of being able to convey exactly the way that we have been looking after them. I think are getting better at being able to provide the communication in terms of our notes and things like that. Mm-hmm. But they may not have, on their end, they may not have the same set of resources. Sure. So if we're discharging from an organization like Ontario Shores, which is a multidisciplinary team of providers that has psychologists and social workers and nursing and other allied health resources, and you're discharging to a community-based agency which largely relies, say, on registered practical nurses, patient care attendants or something like that, they may not have the ability and capacity to manage very difficult sort of emerging issues for that individual. So sometimes it's individual and sometimes it's the system. The system's not been able to tie all of that together tightly in a way that allows the resources to flow where it's needed.
I often found, both as a patient and then later as a clinician, often shocked, especially fresh out of grad school, how unscientific sometimes the treatment pathway seems. That, I experienced this myself. You go in, you maybe get visited by a psychiatrist for 15 minutes, and then you're just left to your own devices on the ward for the rest of the day. And that, to me, there was never really a whole lot of, okay, what's going on here? What are the medications? What are the symptoms? What's the strategy? And then especially, what are the goalposts? What are we trying to get to, and how do we measure and monitor? It never seemed like all that intentional of a process. So, being a Center for Mental Health Sciences, part of the name, how is that different at Ontario Shores?
So it is. It's so I'm not sure that I could say to you today that we are there. But what I'm going to say to you is we're probably further along than any other institution in the province on this issue.
How so?
Well, so about 7 years ago, we began work, at Ontario Shores that started to look at standardizing care. And standardizing care, the sort of objective is to take away the variability. Exactly what you were describing. So when any clinician approaches you, what is the objective of that interaction?
Right.
It shouldn't be just about, I'll just go and see Mark today, but what's the intent and purpose of that interaction? So we began that work about 7 years ago, very specifically to try and address the issue of reducing variability. And we chose 3 areas that are predominant in terms of our volume of service: schizophrenia, depression, and dementia. And we established teams internally that took a view of the literature sort of jurisdictionally across the planet, and said which one, where can we find best guidelines for the treatment of these areas for inpatient care. And we started to establish clinical pathways for each one of those conditions. Then about 2 years into that journey, Health Quality Ontario, which was the government's agency that was mandated to develop standards, started to think about standards for mental health. And they talked to the system, and they talked to many providers in the system and asked for what would be the areas that they should begin the development of these standards. And they talked to us, and we said those 3 areas that I described a minute ago were probably the right ones for inpatient care, and that we could assist them in actually developing these standards. So of the 3, they set up sort of committees and of experts to review all 3 of them, and they wanted to develop standards for all 3 of them. And 2 of those committees, if you will, were co-chaired by clinicians from our organization. We then had the opportunity, once Health Quality Ontario completed their work, to start to talk about how do you implement that. Now, the implementation science across healthcare is weak at best. And so what we did is we took all of those standards, and there's no other organization that's done this. We took every one of those standards and the statements that are associated with those standards, and there's typically about 15 statements associated with those standards, that have been then proven by all of those experts as these are the things you have to do in order to be able to be successful in the treatment of that particular condition. So we took each one of those statements and we embedded those into our electronic health record. Now, Ontario Shores, one of the things about Ontario Shores is that we are great innovators. We began life, like literally we're in our adolescence, only a 13-year-old organization. But in order to be able to really catch up, if you will, to the mature organizations, we have really relied on innovation as our driver.
Sure.
And so one of the things that we did was introduce an electronic health record about 10 years ago into the system and have continued to develop that. So we are the first organization in Canada to have been declared a HIMSS 7 organization.
What does that mean?
So the HIMSS 7, HIMSS is a standard-setting body. That it's an international standard-setting body that basically evaluates all the electronic health records that individual organizations build, and then indicates whether or not you're a paperless organization that in fact is relying on business intelligence to drive clinical change and clinical value.
Yeah.
So we were the first organization in Canada to be declared a HIMSS 7 organization, which is the highest level of capability. And we were the first behavioral health organization or mental health hospital in the world to be declared a HIMSS 7 organization. Shortly after that, we also won the Davies Award, which has only been given to 77 organizations across the world, and we were one of those. The reason I mention that is that because of that capability, because of that fundamental infrastructure that we had, we were able to take every one of those statements and we were able to embed them in our electronic health record.
Right. And then how did that translate to actual clinical practice?
Right. So what happens is, as somebody comes in, say with schizophrenia, their entire clinical pathway pops right up.
Okay.
And it says, here's what you're going to need to be able to do. Here's the prescription that you're going to need for family intervention therapy. Here's the prescription that you're going to need to be able to do for clinical behavioral therapy. And we start to actually implement based on evidence.
Yes.
And you take away the variability.
Yeah.
So it's the evidence which starts to drive the manner in which, and then the evidence tells us this is what we need to do day 1. This is what we need to do day 15. This is what we need to do day 22. And we are able to actually follow a pathway to be able to then accelerate the recovery of the individual and back out into the community. So reduction of variability has been core, and evidence-based has been core to the way in which we are driving care at Ontario Shores. And to me, that's how we're really combating this notion that what exactly am I expected when I come in for care?
Well, and I read studies all the time about these great treatments happening in laboratory settings, and I read them and think that's amazing that this particular treatment or medication achieved that kind of results, but that is completely unfeasible in the real world in a naturalistic setting because none of these variables are monitored. It's not you can't change what you don't measure, as they say. So it sounds like you're turning that on its head, that entire approach.
Yeah, absolutely. And then what we are doing is actually monitoring by clinician, by program, by organization, our adherence to those standards. And so we are able to, for example, tell you today, I can say to you, we have 80% adherence across every single statement and standard for those 3.
In terms of your clinicians administering according to the flow. So then what kind of impact has that had on outcomes? Are you there yet?
So we're dropping our length of stay dramatically. I mentioned to you that, over time it's come down quite considerably, but even in the last 2 or 3 years, it's come down quite considerably. We can also show, based on various scales for depression, example, with the GAD-7 or PH9 scores, what people are doing in terms of their improvement, what their base was when they came in, and what their improvement looks like on discharge. So we're able to demonstrate all of that as well. So that information we share. What's the recovery on the RAS score, and what's the recovery on these scales, and we actually publish that on our balance scorecard as well.
You've been characterized as having a leadership style that encourages open and honest conversations, ongoing training, and being as human as possible. You would think that it would be the most necessary piece to have humans who are caring for people who are most vulnerable. But then how do you keep the humanity and the latitude for individual difference, both for your clinicians and your professionals, but also for the patients who are coming to see you? They often don't want to be standardized. Nobody wants to be standardized in that kind of way, right? In terms of all fit into a box.
Yeah, so there's a lot in that question. I'll try to sort of unpack it a little bit. One of the great challenges for clinicians is trying to marry, if you will, the art, which is the humanity piece that you were referring to, the art of caring for somebody, the humanness, with the evidence that exists. And it does have to be brought together. You can't flow too far one way.
Right.
Or the other.
Well, people actually aren't as different as they think they are.
Yeah.
Right?
So you look at the popular literature or the scientific literature, not the popular literature, but the scientific literature, and you say here's evidence of X, and it typically takes 15 to 20 years for that evidence to find itself from the journal in which it's first published to practice. And it becomes a natural part of the delivery of care. And that's wrong. That's wrong because we spent vast amounts of resources to develop that knowledge, and then we're wasting that capacity for 15 to 17 years, and people are suffering in a manner that we could have alleviated if we had brought the evidence faster into practice.
Well, and then often, whether, especially not scientists, but clinicians and governments, they don't want to often go back to a 20-year-old research paper, a 15-year-old research paper.
And so they go on.
Exactly. So nothing ever gets implemented.
That's right. So for us, it's shortening that, right? So all of our clinical pathways, all of our evidence is reviewed every 2 years. And the notion is that we go from that 15 to 17 year time lag down to 2 years, so that the evidence is what helps clinicians feel confident that they're doing the right thing by their patient. And, at the end of the day, clinicians are raised in a scientific environment. They experiment, learn, they apply. And so they're programmed, if you will, or they're faced with this notion of what's the right evidence to be able to apply for this. So we can offer that. The other part of it is, of course, the humanity and the compassion that they bring. And I mentioned to you that when we began our journey as an institution, we began that journey 100 years ago. And the one thing I told you that didn't change is the love and compassion that our people bring in the care that they deliver. So you have to be sensitive in your hiring process that the individuals that are joining your organization cherish the same values organizationally that we are embodying in the care that we deliver. So it can't be at the expense of one or the other.
And it's been shown several times in research that people with lived experience report that they receive the most stigma from frontline care providers, right? So how do you counteract that stigma within your own people?
You raise an important point. There's nothing more challenging for a provider, like an institutionally provider, or for that matter, I guess like if you think about the individual that you meet at the cashier, there's real differences between individuals who are doing that same function.
Right.
People who perhaps have been there, not always, but perhaps have been there a very long period of time, and they are just interested in, having you go through that line and get out the other end, and
so they can get home and have supper with their family.
Right. They can check out, and they don't have to do anything unusual in their day.
Yeah.
And then there's a person who's just got that infectious smile on their face, and they're talking to you, and they're engaging with you, and all of a sudden, the process of getting your items on the conveyor belt and then bagged out the door is a pleasant one. And that's no different.
Yeah.
In any aspect of human interaction, no matter where you are. And that includes healthcare.
I experienced this so many times working as a clinician where I'd go with a client to hospital and I would leave frustrated, feeling I should not get better customer service buying socks at the Gap than I get with somebody who is in their most vulnerable place in their life, right? Just being courteous, and they're simple things. So how do you actually communicate that then to your frontline people that, this might be your 100th time doing this intake today, but it's this person's first time and it's really hard for them?
You try desperately to appeal to what brought them to care in the first place. Like sometimes it's about the individual again, like just as we were talking about. So, Karim as the care provider can change, and their life experiences are such that they no longer have that same degree of commitment and energy, and so we can talk about how we are helping manage that. We'll come back to that. And then there's the environment in which that person is working, in which they feel beaten down and trodden upon, and they no longer are excited about the prospect of looking after someone who's going through that very difficult time in their lives. And so what we want to be able to do is, first of all, connect them to why they came to the profession in the first place. Because people who come into mental health care, they're very special people.
Yeah. Almost everyone has a story of their own.
Absolutely.
Yeah.
Like they could have chosen any variety of subspecialties.
Certainly more profitable ones.
Absolutely. Again, like they could go, but whether it's the medical profession or whether it's nursing, they could go into things that are much more sexy and exciting, and they can go and be in an ICU, or they could go and look after peds, young children. But they chose to come into mental health. And so what is it that brought you here, and how do we keep that alive and that compassion reemerge? And so I think there's two things that we have done. One is that we really focus on the wellness of our staff, and we offer any number of different things. So we look, if you ever go on our website, we have something called the well-being wheel, well-being, that includes about a half a dozen items around it. So there's financial well-being, there's physical well-being, there's spiritual well-being, there's physical well-being, like we have a whole host of psychological well-being. And we have programs that are targeting every one of those items at the organization, plus resources that they can avail of themselves in any one of those areas. The whole idea is that we want to ensure that the individual, if life has been difficult for them, they're going through difficult times, have access to all of these things, which should be able to strengthen and build up their resiliency once again. The other thing that we do is we constantly educate. So we went through something called Shared Journey about 10 years ago, maybe 11 years ago, where we took the entire organization through the life of what it meant to be someone who suffered from a mental illness. So it didn't matter who you were, whether you were the CEO, whether you were a senior management team member, whether you were an environmental services worker. We took everybody through the same program to reacquaint them to that interface between someone who's unwell and you as a provider. And we've tried to keep on top of that by introducing other programs like mental health first aid and other programs which reinvigorate for people the idea that they are a part of this healing process. And in being a part of the healing process, A, you have to take care of yourself. B, you have to be well educated so that you know that what you're doing makes a difference. And it makes a difference in every interaction that you have. So those are some of the ways that we try to counter what can sometimes be just difficult day in, day out interactions with people who are suffering.
Why do you think that you got into this? I mean, why do you get up every morning and go work at a psychiatric hospital?
I've been in healthcare my entire career. I graduated with a master's in business administration back in 1990. So it's been almost 30 years for me. And with sort of a specialty in finance and health systems management. And the reason why sort of harkens back to when I first came to Canada. So I was born in East Africa. I was born in Uganda. And in 1972, there was a coup that occurred in Uganda. And many of the people who, we were citizens of Uganda. My parents had been born there. My grandparents came from India and settled in Africa. We'd been there 2 generations already. But there was a coup that occurred in Uganda, and the order was that everyone who was non-black, non-Ugandan citizenship had to leave. And so we were literally the second last plane to leave from Uganda. And we left everything behind. We came to Canada, and we landed at Mirabel Airport. It was in November. And I remember coming off the plane, and at the time I was a very young boy. I was in my shorts. We just come from East Africa. It was warm. I was landing and it was snowing. Like any child that comes off an airplane and sees snow for the first time, you just run into the snow. It's just like, this is wonderful. Wow, look at all this. Of course, not realizing, A, it's cold, and B, I'm wearing shorts, and boy, this is really going to sting in a minute. But there were people there who were waiting for us. And I learned after the fact that there were people from the Salvation Army, and they were receiving refugees that were coming from Uganda. And somebody ran up to me and enfolded me in a blanket and made me warm. So my first impression of coming to Canada was this incredible experience of someone's warmth and love for me as a human being, escaping a terrible place. And so when I reflect on the things that are truly special about Canada, 2 things come to mind. One is healthcare. It's that warm blanket around us. It's knowing that if I get ill, I'm not going to be bankrupt. I'm not going to be thrown to the side. The society loves and cherishes me as a human being and will nourish me to be back to who I was before the illness. So healthcare is this incredible commodity that as Canadians, we have to preserve. And the other is education. So I, as a refugee, had access to education. And I had access to affordable post-secondary education. My parents weren't wealthy. They weren't able to provide me the resources to go to post-secondary education, but I was able to borrow enough to be able to do that. Those 2 things have to be the things that preserve Canada going into the future. They're the things that level everything in the Canadian context. Anybody who works hard enough knows that they can go through education and have the support that if they're not well, that they can still come back. And to me, preserving healthcare became the driver. And so as I chose the pathway that I am following today, it was about finance, the systems costs, and healthcare. And how do I bring those 2 things together so that the future is about preservation of our incredible healthcare system into the future? Because as taxpayers, if we no longer trust the value that we get for healthcare, then we are more likely to start to abandon the current system and think about bringing in more private, perhaps, systems. Mm-hmm. And to me, that would be a total failure of our generation if we allow that to happen. Mm-hmm. So my view is about every single day, do we create value? Can we demonstrate that value? Can we show that the money that the taxpayer is giving to us is actually being turned into something that is valuable to society? And if we can do that, then we preserve the opportunity for our children and our grandchildren and their children to actually receive health care in this incredible, compassionate way that we've become used to. So that's what drives me.
Karim Mamdani, CEO of Ontario Shores Centre for Mental Health Sciences. Thanks for coming on the show.
My pleasure. Thank you so much for having me.
There we go. There's my conversation with Karim Mamdani. He's the CEO of the Ontario Shores Centre for Mental Health Sciences, or Ontario Shores for short. I loved talking to him about his own story of coming to Canada as a refugee and having that warm blanket wrapped around him, and now the work that he does to help wrap that blanket around so many other people in a warm and caring way. He really is an inspirational leader in the sector, and I look forward to seeing more of the developments to come out of Ontario Shores, in particular with their scientific approach to treatment and recovery. I think that's refreshing and well needed in this space. So if you enjoyed my conversation, I'd also suggest that you check out the one that I had a few months ago with Catherine Zahn, Dr. Catherine Zahn, the CEO of CAMH, the Centre for Addiction and Mental Health. And we've had a number of other physicians and healthcare providers on the show as well. So go check out all those episodes on Apple Podcasts. While you're there, subscribe. Scroll on down to the bottom, leave us a star rating, leave us some comments. I do read them and I love them. And you can also get us anywhere else you download your podcast. So if it's not on Apple Podcasts, you can head over to Google Podcast, to Spotify, Stitcher, Deezer. We're on YouTube. These get posted all over my social media as well. So you can follow me at Mark Hennick. That's at MarkHenick. You can head over to my website, markhennick.com, and I post quite a few of them up there as well. As always, let me know what you think and send along any questions or guests that you want to hear from in the future. I think that's it for me, so I'd like to thank everyone at E1, Kimberly, Adrian, and everybody else, my editor, Dave, for making all this possible, for really making this a fun and educational experience for me especially. That's it for me. I'm Mark Hennick. Thanks for listening to So-Called Normal.